Hello and welcome to our lecture on chapter 43, where we're going to discuss structure, function, and disorders of the integument. We'll start off just doing a brief review over the layers of skin. Remember that the epidermis and the dermis are the two layers that make up our skin. Our epidermis has several layers, starting with our most superficial layer, the stratum corneum, and moving on down to our stratum granulosum and stratum spinosum, where we have many keratinocytes, and lastly our stratum basale, where mitosis takes place, and we also see our melanocytes here that are going to secrete melanin to the other layers of the skin. And then beyond that, we are going to have our dermis. So down over here, we see the dermis, and within the dermis, we've got our sweat glands, our sebaceous glands, our hair follicles, lots of blood vessels, and nerves as well. Now, making up the area below the skin is going to be our hypodermis, or it's also referenced to as our subcutaneous tissue or superficial fascia. And within this layer, we're also going to have blood vessels and nerves, and it will help to insulate and cushion the body. And we have other accessories of our integument system, which we don't see here. Well, clearly we see the hair follicles over here, but we also have our nails. So you could see the makeup of our nail plate and the skin surrounding the nail, which we call peronechium and the epinecium. And the lunula is that half moon structure. And we are also going to see a hyponechium, which we can't see from this view because we have part of the nail in the way, but in this sagittal view here, we see the hyponechium right underneath. And of course, we have all of the matrix down in this area where we will have mitosis taking place in order to create our nail. So the first thing we're going to do is talk about primary lesions. We will go into more detail in following videos, but I thought it'd be good to do an overview first of some of these terms. So we'll start with macule, and this is going to be a flat, circumscribed area that is a change in the color of the skin, and it's less than 1 centimeter in diameter. So examples of this, what we see are freckles, a flat mole, which we call a nubby. So you can kind of see that pictured over here. Petechiae is a good example, the measles, or if someone suffers from scarlet fever. Next, we have papule, and this is when we have a little bit more elevation, right? And so this is going to be pretty firm and circumscribed and still less than 1 centimeter in diameter. Examples of this would be warts or our elevated moles. Here we see pictured is a lichen planus, and we can also see it in a fibroma or if someone were to get an insect bite. Next, we have the term patch, and this is going to be more flat. We can't really feel that it is a firm bump or anything like that, and it's irregularly shaped, so you can kind of see this border, ruffled border here. And this tends to be greater than 1 centimeter in diameter. So we do see it in conditions such as vitiligo. Here we see a port wine stain, a Mongolian spot or several spots, and cafe au lait spots, which we see over here. Next is a plaque, and this time we do see some elevation and it is firm. It's going to be a rough lesion with a flat top, and the surface is greater than 1 centimeter in diameter. So examples of this would be psoriasis, which you could see it pictured here. I also forgot to mention at the beginning of this video that I will be doing my best to give you a variety of skin tones of these different conditions, just so you can recognize what it would look like in someone with darker skin or with someone with lighter skin. So moving on, we also have an example here of seborrheic keratoses, and you could see it's kind of like clumps, or like it looks like it's cracked. And also actinic keratosis, where you can kind of see a little bit of a raising over here. Next is a wheal, and in these we are going to see that it is elevated, and we will have it on an irregular shape as far as the border. You can't really see that in this illustration here, but we'll see examples of it, as you can see in the many pictures over here. and it's going to be an area of cutaneous edema. So you can kind of see that it's a little thickened in this region, and it's solid and transient, and the diameter can be variable, which we see over here where we have urticaria. There is large spaces in which it is affected, and we do see that irregular border. And in other times we have insect bites, which are going to be much smaller. And these are just some different cases of urticaria. Next, we have a nodule. Now this has elevation here, but you could see that it is due to this area in the dermis. So it's a bit deeper. It is firm and a circumscribed lesion. And this is going to be anywhere from 1 to 2 centimeters in diameter. So you could see examples such as lymphomas, and here's one in the hand, as well as our erythema nodosum, where we can see in someone that's a little bit lighter, you see a bit more red to it, whereas in someone who's darker skinned, it's a bit more of a dark brown or a black. Next, we have a tumor, and this is going to be an elevated solid lesion, and this may be clearly demarcated, like we see over here. It could be deeper down in the dermis, although in this image we see it's more within the area of the epidermis, and it can be more than 2 centimeters in diameter. So we have some examples here, although I don't have pictured neoplasms or a benign tumor. We saw lymphomas in the previous slide, but here's an example of a neurofibroma, and the rest of these are examples of hemangiomas. And they don't necessarily have to be this large, but I just wanted to show you the more superficial and then how they can also be deeper or put together. So here we see the combined form, and here is another example of that, but they can also be extremely small. And then we have vesicles. These are elevated and circumscribed and superficial. We don't extend down into the dermal region, and it could be filled with serous fluid. Typically, they're going to be less than 1 centimeter in diameter. So we see some examples over here, the many little spots, and examples are going to be in people that have a varicella virus causing chicken pox, which we see that over here. And also people who have the herpes zoster virus, which can erupt later in our life and cause shingles, and also herpes simplex. So here's a case of herpes simplex 1, and we also have examples of this bulla, and in this case it's larger than 1 centimeter in diameter, and a bulla is a large blister that is containing serous fluid. Other examples would be blisters and pemphigus vulgaris. Next, we have a pustule, and this is going to be elevated. It is superficial, so found in the epidermis, and is similar to a vesicle, but it's filled with a purulent fluid. So cases of this would be impetigo, and you could see the differences between the skin tones here, as well as acne. Next is a cyst, where it's going to be elevated and circumscribed. Notice how it's an encapsulated lesion, and we can find it either in the dermis, like we see here, or in the subcutaneous layer, or the hypodermis. And it could be filled with liquid or a semi-solid material. So examples would be a sebaceous cyst, so we could see one over here, as well as this one behind the ear, or it could be in the form of cystic acne. Next, we have telangiectasia, and this is when we have very fine irregular red lines. They could be anywhere from 0.5 to 1 millimeter, and it's produced by capillary dilation. And we can see this associated with rosacea on the face, and it could also be associated with a venous hypertension, which is the spider veins in the legs, systemic sclerosis, or developmental abnormalities such as the port wine birthmarks. And we can see another example over here where those fine lines quite aren't as easily distinguished because of the rosacea. And then here is how it looks in somebody that has darker skin. So those were all primary lesions. Now let's talk about secondary lesions. Now our primary lesions are the ones that develop as a direct result of the disease process, whereas the secondary lesions are going to be evolving from a primary lesion or develop as a consequence of the patient's activities. So we're going to start off with scale, and scale is a heaped up keratinized cell area. It can be very flaky, which you can kind of see from these photos over here. It could be thick or dry, irregular in shape. Dry most of the time, but it can also be oily. You can kind of see a bit of a shine here, and there's a variation in the size. So like I said, we could see some flaking here, and that could present itself with some seborrheic dermatitis after someone has scarlet fever, or it could just be flaking of skin after a drug reaction, or dry skin in general. Next, we have lichenification, and this is when we have a rough, thickened area of the epidermis. You could see how that stratum corneum is a bit thicker here, and that is secondary to persistent rubbing, itching, or skin irritation, and it often involves the flexor surface of a extremity. So we could see that right within this area at the atopic dermatitis. This is the area of the heel, and you could see the many ridges in here. We also know that this is the area of the ankle, so we can have dorsiflexion take place that can cause the lichenification to take place here. And this is the area of the knee. Even though it is not an area of flexion, it could still take place there. Next, we've got keloids, and these are irregularly shaped elevated areas that are progressively enlarging scars, and it can grow beyond boundaries of a wound. That's what first initiates the keloid to take place, is there's some type of wound, and then we get an excessive buildup of collagen that forms during the healing process. So here are some examples of just regular keloids, and it could take place after surgery or some type of injury. Next, we have a scar, and this is when we have thin to thick fibrous tissue that replaces our normal skin after an injury or some type of laceration down to the dermis level. And when it heals, we see that there are sometimes more of like a silvery white line that courses through them, and that is due to the collagen fibers trying to bring the two areas of the skin together. And so examples would be a healed wound or surgical incision. Next, we have excorication, and this is when we have a loss of the epidermis, which you see pictured here. It is linear and hollowed out and could be a crusted area. So an example would be an abrasion, which we see pictured over here, or it could be a scratch, or scabies, which I put a picture here of scabies taking place in someone with dark skin and light skin. Remember that this is a condition in which we have a tiny burrowing mite that will go underneath the skin and into the epidermal region and cause intense itching in an area where it burrows. And as a result, we get a itchy skin rash that you see pictured here. Next, we have a fissure, and this is where we have a linear crack or break within the epidermis down to the dermis level, and it could be moist or dry. You could see more of the moist over here where we have a fissure from an infected dermatitis. And examples would include athlete's foot, when we get cracks in the corners of the mouth, and this is termed angular cheilitis. And you can also have an anal fissure. I know this is a little blurry, but there is a fissure in this area, and just regular dermatitis. So you could see some cracks here in the heel. Next, we have erosion, and this is when we have a loss of a part of the epidermis. It's depressed, moist, and glistening. You could kind of see that glisteningness over here, and it typically follows a rupture of a vesicle or a bulla due to external pressure, or it could be due to chemical injury. So here are some examples of chemical injuries that have led to erosion. Next, we have an ulcer. This too is a loss of the epidermis, but now we're getting deeper down into the dermal layer, and it's concave and it does vary in size. We're going to talk about this extensively in an upcoming video. So examples would be something like a pressure ulcer, which we see pictured over here, and also venous or stasis ulcers. So you could see different examples and levels of that. And then we have atrophy. This is when we start to have thinning of the skin, and start to lose the skin markings. And so it appears translucent and paper-like. You could see here in an aged hand how much thinner the skin is. And also we have examples of striae where we see a thinning of the skin and also almost like a stretching of the skin that leaves these lines. So before we end this video, let's talk about our pressure ulcers a little bit more in detail. They are going to result due to any unrelieved pressure on the skin causing underlying tissue damage. So if you think about how a patient is laying down, typically they are going to be adding pressure to the areas of the sacrum, your heels, the ischia, or what we know as the sits bone, and then the greater trochanters, which are highlighted right over here. So in these images, we can kind of see the different stages of pressure ulcers. So when we have a little bit of pressure in an area and then we remove that pressure, it is within a few hours, we might have a little bit of redness and then there's no tissue damage. So just the area of the epidermis is a bit affected. But then as we add pressure to that area for hours, for days, then we're going to start to see that the endothelial cells that line the capillaries within this region are going to become disrupted and start to aggregate. And I actually think I'm getting a little bit ahead of myself. Here are the platelets aggregating together, and that starts to occlude the blood supply to that area and causes a noxic necrosis of the surrounding tissues. If it progresses, then the necrotic tissue can initiate an inflammatory response with pain, fever, and leukocytosis. So as nurses, of course, you want to prevent this from taking place. So we can do some preventative techniques such as frequent skin assessments, repositioning the patient. You can see here's an example where you're rotating the patient. And then we can have a pressure reduction or removal and distribution and elimination of any moisture. So if your patient does have a superficial lesion, we do want to make sure that we are changing the dressings so that they are not wet dressings. Then let's go into a bit more detail about keloids and hypertrophic scars. So our keloids we mentioned are these elevated, rounded, and firm lesions. They can have claw-like margins that extend beyond the original site of the injury, and we tend to see that people that have darker pigmented skin will be more prone to having these keloids, and they can appear anywhere from weeks to months after a stable scar has formed. Our hypertrophic scars are going to be these elevated erythematous fibrous lesions. They don't extend beyond the border of the injury and can appear anywhere from 3 to 4 months after an injury takes place, and then it could regress within a year. Now, both of these lesions are going to be caused by excessive collagen formation during the dermal connective tissue repair process. And lastly, we'll talk about pruritus, which it basically means itching. It could be due to multiple stimuli and is associated with primary skin disorders and systemic diseases, and can interact with pain sensations. And these are due to unmyelinated type C nerve fibers that give you the sensation of itchiness. And it could be acute or chronic, which we would call a neuropathic itch, which may be difficult to treat and manage because you have to locate what the cause of the itching is. So once you know the cause of it, it would be easier to use something like topical or systemic therapies in order to treat the itch.